So we start the session on youngster versus masters. My first question is to Dr. Abhay sir. Any specific precaution, especially when you are adapting the temporomandibular joint prosthesis, like we need a dual incision. Any take on how you get the approach right so that your prosthesis placement becomes much more easier? And is there any specific instrument that we need to use so that it becomes easy or quoted in literature, sir?
When you plan for a TJR, Lakshmi is asking is whether how do we take precautions when you have two separate incisions?
Separate incision, extraorally.
Extraorally. When you have a preauricular or an endoral and a periangular or a modified submandibular, the basic essence is what Sonal spoke about, the Hayes-Martin maneuver, what we developed from our oncology friends. But today with the advent of periangular approach, it becomes much more easier. My take on periangular is, I identify the skin subcutaneous tissue. We see the platysma. Once you have seen the plane of the platysma, you go a little above the platysma and open it in such a way that you get to see the masseteric muscle attachment there. And then I always do the periangular incision first when you plan for a TJR, for the very reason that if you have a bleed which happens during the TMJ prosthesis, you can readily access the carotids through your neck incision. So always do your periangulars or your submandibular incision first. Suppose you have an IMA bleed and you can't control it with packing, pressure, platelets and prayers will work at the end. I would do this first and then the preauricular. Now how do we get that entire prosthesis onto the ramus of the mandible? Previously, when we were PGs, what we saw was a gauze piece would be put inside from the submandibular and got out of the preauricular, and you would see that the postgraduate is holding the entire gauze which is stuck onto an artery forceps. But today from our pediatric colleagues, what I have learned is you have the pediatric urethral dilators. A urethral dilator is available from size 1 to size 20. So you pick up one of the sizes of the urethral dilators, starting from 1, push it into the submandibular incision and get it out from the preauricular. It's like a conical shaped dilator. So by the time you start from 1 and reach number 5, it happens so that your entire fist can go inside that space. My fist can go inside, any of your fists can. So your instrumentation is dependent for the amount of access you need.
Is it called the
Hegar's dilator? It's called the Hegar's pediatric urethral dilators.
Okay, sir. Thank you. Could there be a chance there, if it's a recurrent case of as you already mentioned in your presentation, that you had a case where there's a recurrent case of TMJ, bilateral ankylosis. So, in terms of the prosthesis, like suppose if you look at this particular scan, the amount of resection of the release and how should we correlate the amount of your prosthesis component?
It's again based on your virtual surgical planning,
yes,
or your VSP. If there is, this patient has ankylosis with a significant facial deformity, you would then definitely plan for a simultaneous orthognathic surgery as well. But remember, you need to get the bite back to the patient as well as the facial prominence. So your vertical height of the prosthesis is determined by the amount of resection, which is almost always 1.5 centimeters as Kaban put it across. You're staying above the mandibular foramen.
Yes.
And invariably you're resecting 1.5 centimeters of bone. That's how you plan for on a virtual surgical planning. In this particular case, there is a definitive ankylosis there on both sides.
So it seems to be a slight differential presentation.
Differential presentation on the left compared to
the right.
So your VSP has a role.
Yes.
Yes.
I have another question for you, but we have in an ankylosis case, does your approach changes depending on the medial extent or the extent of the ankylotic mass? If the mass is more, probably you've got a type 3 or a large chunk of bone.
Whether it's a Sony's type 2 or a type 3 or a type 4, if it's a type 2, it's lateral arthroplasty. There's no reason for a TJR. Remember, TJRs are the last resort. Every joint need not have a TMJ replacement done. If there is failure from the part 1 to part 5 and the last resort is then a TJR, but believe me, approach stays the same. If you can access a joint with your endoral or your incision, it is still accessible with any kind of incision. When you're doing a TJR, your main focus is for the fossa prosthesis to sit. When I say that when you have a Lauritsen type 2 or a hemifacial microsomia, where there is a missing auricle as well, where there are preauricular tags, and you have an extended fossa prosthesis, where you're taking your anchorage from the mastoid, Santosh, where you're taking your extended prosthesis is so big, then you will have to do a nice Alkayat Bramley incision, because you want to anchor the fossa to the mastoid. Only in those situations, you will have to plan what we call as inverse planning. That means you need to consider your final closure in mind and then plan your incision. You know, once you put your fossa prosthesis and your incision doesn't close, then you will end up doing a rotationary flap. So that's the area where it is of concern regarding the approach. Otherwise, all incisions can give you good access to the TM joint fossa related processes.
I asked this specific question because most of the youngsters, we think that in case if the chunk is more, we might have to go for an extended approach. So whatever approaches which we thought right now, it's necessarily can use the same for most of the TM joint approaches.
Sankalp sir, if a situation where there is a bilateral presentation of internal derangement, you specifically showed us certain disc procedures. So is there anything that would be different in a bilateral case, sir?
In most of the bilateral cases, usually we operate on the side which patient is having maximum problem. So first we operate on the side which patient is having more problem, and many a times we have seen that we operate on one side and other side problem also solves. But if the problem persists on the other side, then we prefer to operate in another surgery, maybe after 1 month or 2 months.
Okay, thank you. This is for Dr. Sonal. I think you mentioned about a very specific thing about transverse facial artery and the preservation of the perichondrium per se. So, in investition, like, have you encountered where you've punctured or got into the perichondrium and had any complications related to the cartilage?
I think in the initial times, or maybe when somebody else was doing it, we did have a small cut in the cartilage, but I think we just put a small suture through it, some 6-0 or something, and it was fine. But you don't want to do that, right? You don't want to cut the cartilage. It may be fine, it may not be fine. You don't want to denude the entire cartilage of the perichondrium, because that's the blood supply goes through there as well. So it's not like there's a problem, but there can be. So you don't want to, do it. You don't want to cut cartilage, basically.
So it could be a mistake and then,
yes.
but not major complication.
No major complication, because it was just a nick. But see, that is why this is a little more difficult than your regular preauricular, because you don't have to go here. It is like exactly waiting and then exactly cutting through the skin, and then exactly kind of going around the ear cartilage, right? So it's a little more difficult going behind the tragus, coming like this, then coming outside the tragus. So it's a little more technically, sounds difficult. So you should probably start with a preauricular, then you can maybe go to an endoral, and then maybe you can go to an indecision.
So there is a arc of learning.
Yes, it is there for it.
Ma'am, some question. To extend the same question for both yourself and Dr. Abhay. In case if somebody ends up having a rent, probably into the external costic meatus, because I heard even a couple of people telling that's a problem. How to manage it? Because I'm sure youngsters can end up having a rent.
No, initially what happens is when you plan for your TJR, once you're planning for your TJR and once you've done your dissection, remember the external auditory cartilage has a tendency to go in and turn out medially. So how do you prevent a rent? Simple. If you are the chief surgeon and you have an assistant who's standing by you and you're dissecting, all you have to do is tell your assistant to put a little finger into the external auditory meatus and push the external auditory canal anteriorly. So when he's doing that, automatically your dissection should stay away from the cartilage. Suppose, worst case scenario, you perforate the external auditory cartilage. I'm not talking about the middle ear. The external, the cartilage. And you put in your joint prosthesis. It has happened to me in my initial days. Post-operatively, patient was leaking from the ear. We didn't understand what was happening. Then we realized that there was a perforation somewhere. Now, are we looking at a periprosthetic joint infection? Unlikely if you identified it. So what I do is I put a small Vaseline soaked gauze inside the ear, keep it there for first 72 hours, and then examine after 72 hours. And then slowly taper it and see for a granulation to form. But excess granulation is also a headache. That's the way you manage it. And even if you send it to an ENT surgeon, you cannot do any wonder.
In case if you find out intraoperatively there is a rent, is there any preventive measures
even if you take a bite from it, it will just open up. It's like taking a bite through a friable tissue, it's going to open up.
Santosh, a wee technique I picked up was, you're absolutely right, as Abhi says, it takes a slight dive and it turns, and it gets thinner.
Yeah.
It gets thinner as it turns as it comes up to the bony part. What I found is if you get an endoscope, shine the light down at there, you can see the light as you're dissecting down. And as the light gets brighter, you know fine it's getting thinner basically. So that was a little technique. It was actually
it's a beautiful concept what Dr. Andrew is saying about shine the light into the external auditory cartilage from your endoscope, from your NT colleagues. As the light gets and it gets more thinner and passes through the area, you mean to say that it's much more thinner in that area.
Thinner, yes, a lot thinner, so you become a lot more aware of where it is and you avoid the perforation.
Absolutely.
In fact, even that Gary suture where you take a bite to that works beautiful. That gives a good retraction, and it straightens out the cartilage. To get a good dissection.
That suture, we have the article, we'll put it up on the group, okay? You take a suture through the tragus and then pull it behind. We'll put it up on the group, don't worry about that. And so, when I was saying the nicks, they were all the nicks over here, okay, not inside. Inside we've had, I think, one, and that same thing, we put an antibiotic soaked that gauze, we just put it inside, and I think it was okay in 2-3 days.
Ma'am, before you, then one more question, probably on behalf of it. A lot of people know we have done, so when you start operating the temporomandibular joint, the most dreaded complication, of course, Sonal as madam has never got it, facial nerve injury, end up having it.
We have transient.
No. It's just, what's your protocol? How do you manage in case if there is a transient, like
Okay, so whether we have it or not, we do an RD test. We send the patient to the physiotherapy guys. There's something known as an RD test. They put electrodes and all, and then they figure out whether your nerve is working or not. Okay, so that is one. If we've had it, which will last forever, what is that? Rishikesh, would you explain? There is something that will tell you whether it's just a temporary thing, and then something which will tell you it's a permanent thing. What is that?
Reaction degeneration test is called. The basic, actually, the proper physiology is not remember right now, but they would tell you that which muscle is acting on the stimulation of the nerve and which nerve is responding to the movement. So it would tell you that which nerve has a permanent damage and which nerve has temporary damage. SF and IG. There is IG is like galvanic thing, and SF is Serge Faraday. It's called. You can Google it up. It is informed physiology, physiotherapy guys.
So you will know whether it's permanent or not.
So getting on to the next question of sequelae of complications, what about your experience of CSF leak right at the intraop, and how have you managed it?
CSF leak as a component of temporomandibular joint replacements, I have done it. We were preparing the fossa for a custom-made joint prosthesis, and sad to say, during the planning, the cutting guide which was given to prepare the fossa was inadequately fabricated. So I ended up cutting more of the skull base. And immediately when we cut the skull base, at that particular instance, we could see the middle cranium. Now, because there was no apt CSF leak as such, we could see the herniation. So my neurosurgeon, I summoned and asked him. He said, "Abhay, nothing to worry, just put a patch." So we just closed it up with a Surgicel and a gel foam pack there and left it alone. CSF leak per se can happen when you have extensive or very thin skull base where you're preparing the skull base to receive a fossa prosthesis.
Okay. So nothing like a material that can be used at that particular point?
No, nothing. You can use your Surgicel and gel foam and just pack that area like a patch.
Okay.
That's ideal.
We
You can
used
use Dura patch.
Yeah, Dura patch is something which you can.
Dura patch.
Yes,
and
sir.
Also, you can raise the TMP.
TMP.
Give a lining for that. There are two things very handy. And if you have got pericranium, probably that's ideal.
Thank you, Jen sir. Yes, this is just a photograph. So any take on?
If you see the second image,
Yes,
it's a bad case of TMJ ankylosis. with
it's a
limb-
recurrent case in
Yeah,
which it has been
exactly,
replaced.
which is exactly the scenario. You see the angulation of the prosthesis. I'm sure these are stock joints.
Yes,
And that is not acceptable because over a period of time these joints will fail.
and
you
it
see
will
the-
again cause.
Absolutely. You see, that's not the angulation which needs to be given. And that's the reason why these joints will fail. This was a case for a good custom-made joint prosthesis.
Yes, so that's the take home for today. And any specific point in VSP planning? You've mentioned about the prosthesis, you've mentioned about the components, what you mentioned about the angulation. In the planning, is there something that we've missed?
Okay. In virtual surgical planning, when you plan for a simultaneous, give me 1 minute, I'm just breathing. In virtual surgical planning, when you plan for joint replacement and a simultaneous osteotomy, you have to do an inverse planning or a reverse planning where you plan the Lefort osteotomy first and then you plan the TJR in virtual surgical planning. But when in the actual scenario, you're doing the mandible first approach and then laying the maxilla to the stable base. Now, why is that? Because you want to get, in your VSP, you want to get the relation or the AP movement of the maxilla in a proper direction. Again, it is dependent on the point of rotation. So VSP will have maxilla planned first and then the TJR. But in a surgical practice, it's the mandible first. Open the mandible, keep the joints, and then do the Lefort to set it over the joint.
Thank you. Thank you very much. We'll go on to the arthroscopy part now. And I really request everyone to please keep your questions to the approaches. You know, otherwise it's just so huge. We did just TMJ over 4 days in Gyan 5. So.